Johns Hopkins Medicine.
Known for groundbreaking research, teaching, and medical care.
Welcome to Facebook Live from Johns Hopkins Medicine. I'm Elizabeth Tracy.
And I'm Ji Bang, and I'm the Clinical Director of the Johns Hopkins Huntington's Disease Center of Excellence.
Thank you so much for joining me today.
Thank you for having me.
Huntington's disease, that sounds like a big medical term. Is there also a shortened form of that medicine usually does?
Yes, we can say HD.
Okay, so let's refer to it as HD then. Would you please tell me exactly what is HD or Huntington's disease?
Sure. HD is a genetically inherited disease, and it's a neurodegenerative disease, which means there's a problem in the DNA, so there's a mutation, and that leads to an abnormal form of what's called Huntington protein. And that abnormal form of the Huntington protein leads the patient to develop problems with their mood, their movement, and their thinking. And these symptoms are progressive.
I think we have a slide that tells us a little more about it.
Okay, let's take a look. So this is a biology review in a few seconds, and you can see that there's a DNA, and that's like the recipe that makes the protein. And when there's a problem in the recipe, then you might make the wrong food or wrong protein in this case. And in the middle is the RNA, and that's a copy of the DNA that your body makes, so that you don't make mistakes to the original DNA itself, but rather you make the protein from the copy of the DNA, which is the RNA. And in Huntington's disease, the DNA is where the problem is, which is why eventually you have the abnormal form of the Huntington protein.
And what specifically is wrong with this protein?
Right, so when it's in its normal form of Huntington protein, that's essential for survival, so people need it to live. However, when that protein is in its mutant form, it tends to damage the nerve cells in the brain, starting with a specific area of the brain, and then spreads and eventually leads to the nerve cells dying.
My understanding is that while Huntington's was identified 100 plus years ago, we really only know specifically what the problem is recently.
That's right. So Huntington's disease was described by Dr. George Huntington, who himself was a third-generation doctor. So his father and his grandfather also observed these Huntington's disease families over time and made similar observations as he did. And he published that, and this was in the 1880s. And we've known about it, but then it wasn't until 1993 when we exactly located where the gene is.
How many people are affected by Huntington's?
So it's estimated there are about 30,000 people in the US that are affected by HD, or have HD, but then there are additional somewhere between 150 to 200,000 people who are at risk of developing HD.
And what renders someone at risk?
Right, so because it is a genetically inherited disease, if your parent has the HD, the disease, then each child has 50% chance of inheriting that mutant gene, which will then lead them to have HD.
Those are some pretty powerful odds.
That's right. It's 50-50 risk for each child, independent of what the other children have in terms of the mutation.
In view of the fact that this runs in families, I guess I would ask a question about childbearing if you knew that you had this in your family. Right,
so one might say the easiest way to get rid of HD is just to not have any children, and then it will be the end of it. Part of the cruelty of the disease is it affects the way that you think about your future or your ability to reason things. And so if there's an affected patient, they might not take precautions and reproduce. Another possibility is if the person with HD in the family, because the disease affects their behavior, they may become estranged and leave the family, and the rest of the family may not know about the family history of HD, and they might go on having or increasing their family. And other times, adoption can be also an issue. If you've been adopted out of the family, you would not know about the history. And so the disease has managed to survive and make itself perpetuate so far.
Is there an average age at which most people start to show symptoms of HD?
So even though you're born with the gene, people do not develop symptoms until they're in their 30s, 40s, or 50s. And that's the majority of the disease onset age range. However, it can really occur from anywhere between childhood to advancing years, well beyond 50.
How come there's so much variability in the time when it actually onsets?
That's a very good question. So what we know from these observational studies we've done in the past where we follow families with HD, it looks like the general pattern is the longer that abnormal repeat length of the protein is, the earlier the age of onset tends to be. And because people have a lot of different ranges of these extra repeat lengths, that tends to affect the age of onset. However, there are a lot of people who are outside of that expected or that observed pattern, and that can be due to a lot of different either environmental factors or other types of different genetic factors.
When somebody then starts to develop symptoms, what's the most common presentation?
The most common presentation tends to be of motor type and what we call chorea, as in choreography, because it almost looks like it's a dance-like movement. It might be sort of wriggling around or jerking or twitching of the limbs. And when that occurs, that's how we define the diagnosis of HD. Although there are other types of symptoms, so other than movement, it can also affect your mood and thinking. And there can be subtle changes in your thinking years before the motor symptoms really start.
Is there a delay between the time that someone starts to develop symptoms and when they finally get diagnosed? Because since it's so rare, it sounds like it might be kind of a tough diagnosis to make.
That's right, and because the only observable clinical sign is the chorea, it's not uncommon for people to go for some time with only subtle changes and until they're actually diagnosed by a specialist.
Now, here at Johns Hopkins, you are the director of a Center of Excellence for HD. Tell me more about that.
Right, so we are an HDSA, or HD, Society of America Center of Excellence, and the core part of being a Center of Excellence, or COE, is that we provide a multidisciplinary care for our patients and for their families as well. Going back in time, we were one of the first 2 centers in the country that were funded by Congress with federal grant to really delve into HD and put all our efforts into characterizing the clinical aspects of the disease. And that has continued for the past 40 years, and we've been very privileged to be able to serve these families for multiple generations for those 40 years. And what we provide are part of multidisciplinary care is ongoing clinical care for those who have HD and support for them and their families. And we have a social worker who's in the clinic that provides any kind of resources they need, whether that be individual or family counseling or disability applications or finding resources for housing. We also provide genetic testing and pre and post genetic testing counseling through our dedicated HD genetic counselor. And we're there every step of the way as the disease progresses and whatever the needs of the families may be.
So I guess you would encourage people to come to a Center of Excellence if they have this in their family.
Yes, that would be the best way to get a comprehensive care.
The other thing that's going on here that's very exciting, of course, is some pretty powerful research.
That's right. So when we were established 40 years ago, we really dedicated ourselves to both doing research and clinical care. In terms of the research, we have basic scientists who are working at their lab benches trying to really learn more about the biochemistry of the Huntington protein. We were one of the labs that produced this mice model of HD that's really widely used across the world. We also are developing novel MRI techniques and many other endeavors in that area. The other part of our research is clinical trials, and we've been involved in clinical trials, and we've been a leader in that field for many years. And there are different types of clinical trials that are ongoing.
Do you mind describing some of them? And
Yes.
in fact, you already shared with me that there's some pretty exciting ones out there.
That's right. So clinical trial-wise, up until a couple years ago, all the clinical trials that were done were targeted at finding therapies that help improve your symptoms of HD, which is a very important thing. However, until now we are looking at potential therapies that may slow down the progression of the disease or delay the onset of these symptoms, in addition to treating or improving the symptoms. And these are done through specific targeted therapies at the gene.
And I think the slides are going to help us understand that a little
Okay.
bit better.
Yes, let's look at those slides again. So as we talked about, there's the DNA, and you make a copy of that DNA to make that protein. And what these new drugs are doing, which are called either gene silencing therapy or more accurately gene lowering therapies, is that they target the RNA of the Huntington, and there's a drug, if you could go to the next slide. So the DNA part is the HD gene, and then the RNA, which is the messenger or copy of the HD gene, is what the drug called ASO would target. And ASO stands for antisense oligonucleotide, and that's why we say ASO. And when the ASO binds to that part of the gene, that removes that, and therefore you have less of the Huntington protein, which is what we believe is the cause of these symptoms of HD.
But you told me that we all need Huntington protein. What happens then?
Right, and that's under active research as well, because the question is how much of the normal protein can we get rid of and still be okay? And the answer roughly is that it seems like a decent amount can be removed and it won't affect you in a negative way. And that's been established through a lot of different animal model studies, and that's another aspect of what we're looking at with these clinical trials.
You must be so excited by the possibility of a treatment that actually addresses the problem.
Absolutely. The whole community, the worldwide community for HD, we're very, very excited, and at the same time we're trying to be hopeful, but in a very controlled way, if you will. But again, this is a new type of drug therapy, new type of strategies we're using that we think may actually make a difference.
Who's eligible to participate?
Right, so there are different studies for which we're looking for different types of participants. So for clinical trials, such as the ASO therapy that we're conducting now, we are looking for patients who are symptomatic, so they do have HD, and you can see and observe that there are signs that they have the symptoms of HD. But we're looking for what we're referring to as early stage patients, so that roughly means you're still able to walk and talk and carry out a decent amount of your daily functions.
And would this be a good argument then for getting tested?
Right, so that is what drives and motivates a lot of patients or family members to come to our center to be tested. No one can coerce people to be tested, but someone who may not have been tested before because of lack of therapy may now be motivated to be tested because they do have to have the mutant gene and have HD. And in that case, that's where it's important to have that genetic counseling component, because it's it affects the family. It's not just yourself. So if you're interested in being tested because you want to be in a trial, you have to think about how would that impact your parents if they haven't been tested, or how would they impact your children and future generation.
And you said this is such a team approach, so let's take a look at your team. I think we have a slide.
So that's our team. That's our clinical research team up at top, and all the basic science researchers that are part of our center at the bottom.
And we also have this day. That's
right.
Actually an education day.
That's right. We have an annual education day where we discuss all the current research and most recent findings from these research studies. And our next one is on July 13th. And if you have any questions, you can email us or visit our website.
Well, thank you so very much. You've been so very informative. Thanks for joining us today on Facebook Live from Johns Hopkins Medicine. I'm Elizabeth Tracy.
Thank you, and I'm Ji Bang.